It's a complication of an unexpected difficult intubation and the use of a stepwise approach in decision-making for proper airway management. This is a case of a 62-year-old female who presented with difficulty swallowing 2 months prior to admission with an appearance of a left submandibular mass and a weight loss of 5 kilograms. This prompted consult, leading to admission for medical workup. Past medical and family history were unremarkable. She worked as a street sweeper for 35 years, is a known smoker with 7 pack years up until 2 months prior to admission. Physical exams under the neck shows a bilateral palpable, hard non-tender, and non-movable submandibular mass measuring 4 by 4 centimeters on the left and pea-size on the right. She is at the classification 2, Malampati score 2, with a thyromental distance of 7 centimeters. The following are the laboratory results done during admission. She was admitted with a diagnosis of neck mass to consider the following: abscess, thyroid cancer, lymphoma, and extrapulmonary tuberculosis. Upon admission, the patient underwent radiologic exam, initially diagnosed with Cox infection, and started on TB treatment via NGT. However, the main service had difficulty inserting one, hence she was scheduled to undergo the following procedures: EGD under sedation, EGD-guided NGT insertion, possible open gastrostomy tube insertion, and excision biopsy of the left cervical mass. The plan was for her to undergo general anesthesia and endotracheal intubation, with preparation was 8 hours fasting with no preoperative medication. She was pre-oxygenated and inducted with the following medication. An initial attempt at intubation using a Macintosh plate 4 was done. However, difficulty visualizing the glottic opening was experienced. She had a core McLean classification of grade 3, so private pressure was applied, but this failed to help visualization. A second attempt was done and a 7.5 AD tube was successfully inserted. However, the EGD was aborted due to difficulty inserting the endoscope because of a fungating friable mass at the esophageal opening. The surgeon proceeded with doing the open gastrostomy and the incision biopsy. She was then brought to the ICU after for close monitoring for aspiration precaution prior to extubation. Histopath confirmed the diagnosis of squamous cell carcinoma, fully differentiated and metastatic. On the 13th hospital day, 10th postoperative day, the patient experienced sudden expiratory wheezing and increased sensation of esophageal obstruction. On the 14th hospital day, she was unable to tolerate the supine position. Despite treatment with hydrocortisone, combivent nebulization, the symptoms persisted. An ABG yielded the result of respiratory alkalosis, and the worsening condition of the patient prompted intubation at the wards. However, despite several attempts, they were unable to intubate, hence she was brought to the operating room for the procedure with a double setup for a tracheostomy. At this point, a high suspicion of airway obstruction or tracheal stenosis prompted the decision of doing a tracheostomy instead. At the OR, she was awake with exertional dyspnea and audible stridor. She was on face mask with oxygen supplementation of 2 to 3 liters per minute with an oxygen level at 98%. The patient was inducted with the following medications, and she was easily ventilatable with no episodes of desaturation during procedure. This shows the extent of the tracheal invasion done using a vitreolaryngoscope during procedure. It shows a narrowed slit-like tracheal inlet. The patient was under 24-hour surveillance at ICU before transferring back to the wards. She was then referred to radiation oncology for CT simulation and therapy, both of which were not done due to financial constraint. She remained at the ward hemodynamically stable until the 42nd hospital day, when she experienced hematemesis and hypotension, after which she expired. Head or neck mass presents a challenge for anesthesiologists because of the possibility of a difficult airway intubation due to an altered anatomy secondary to mass effect. Squamous cell and adenocarcinoma represents more than 90% of esophageal cancer. Obesity, gastroesophageal reflux disease, Barrett's esophagus, alcohol, and tobacco use are risk factors. Our patient presented with some of the usual symptoms such as dysphagia, anidophagia, hoarseness, cough, and dyspnea. Up to 25% of esophageal cancers invade adjacent structures to the bronchus, trachea, and aorta, inducing airway obstruction via extrinsic compression or via direct invasion due to an anatomical position of the tumor. Besides a stridor, these are usual indications of upper airway pathology or stenosis. In this case, the diagnosis of cancer was confirmed via a biopsy. However, no radiologic assessment was done to confirm the extent of the mass. The rapid increase in size and alteration in anatomy brought about by the mass was a complication not immediately expected. Difficult airway is when a conventionally trained anesthesiologist experiences difficulty with face mask, tracheal intubation, or both. The possibility of not being able to ventilate once sedated may lead to morbidity or even death. A simple structured approach is highlighted by the American Society of Anesthesiologists' difficult airway algorithm, with emphasis given on the recognition of a difficult airway and a decision to find alternative techniques. This includes deferring the procedure or doing an invasive approach similar to our case. The United Kingdom's Difficult Airway Society also recommends limiting the number of airway intervention to 3 attempts plus 1 for a more experienced operator, especially if a blind technique or a gum elastic bougie is used. The following are the usual techniques utilized. As a recommendation, proper preoperative assessment, history taking of previous medical procedures, intubating history, and key airway features are vital information needed to be documented. Radiologic examination is also a beneficial tool. Difficulty in intubation is a common problem in general anesthesia. It is up to the anesthetist to have a preformed plan in this scenario through a thorough knowledge of alternative techniques. So quick thinking and a good judgment is paramount to achieving the goal of patient safety. Thank you very much and good afternoon.